In this video, I'll explain to you how breast cancer occurs, the reason why it occurs, who is at the most risk, and if we can do anything to prevent it. I promise you, you do not want to miss this easy breakdown. Okay, so let's begin with some basic definitions to warm up. So cancer is the abnormal division of cells leading to a mass. This is usually triggered by mutations or abnormal changes in your DNA and genes. When this abnormal division of cells occur in the breast, it's called breast cancer. Now, these mutations or abnormal changes that occur in the DNA can be caused by exposure to certain risk factors. Older age. So cancer is known as the disease of the old. In fact, half of all cancers occur at age 66 and above. The reason cancer develops in older people is simply because of their prolonged exposure to carcinogens such as sunlight, radiation, environmental chemicals, and substances in the food we eat. Next, family history. One of the biggest misconceptions with cancer is that most believe that it's mainly hereditary, meaning because the parent had it, it means those mutated genes will be passed on to their children. I mean, this is possible, don't get me wrong, but also note that only 5 to 10% of cancers are actually hereditary. The majority of cancers are due to acquired mutations from environmental exposures. With that being said, the risk of developing breast cancer increases when a first or second degree relative had cancer. Next, reproductive history. Now, there are two cancers that can be stimulated by some of the hormones in the body. Prostate cancer is one, and then breast cancer is the other. Studies have shown that a woman's risk of developing breast cancer is related to her exposure to hormones that are produced by the ovaries, estrogen and progesterone. Scenarios that increase the levels of these ovarian hormones and also for a longer duration have been associated with increased breast cancer. Let's take a look at some of these scenarios for better understanding. So having your first menses under the age of 12, this means the female's breast tissue will be exposed to estrogen during her menstrual cycle. This means a greater lifetime exposure. Having a late onset of menopause can also increase your risk because during the menopause, the ovaries pretty much stops making estrogen and progesterone. So if you have a late onset of menopause, it means there is a greater lifetime exposure. Having your first child after 30, this increases your risk of breast cancer because when breast cells are made in adolescence, they are immature. The immature breast cells may respond to the estrogen in your body in a negative way. Your first full-term pregnancy makes the breast cells fully mature and grow in a more regular way. This is the main reason why pregnancy helps protect against breast cancer. Being pregnant also reduces your total number of lifetime menstrual cycles, meaning a reduction in the lifetime exposure. Lastly, nulliparity, or a woman who has never given birth to a child for the same reasons as discussed. Next risk factor of breast cancer is having something known as atypical hyperplasia. This is when breast cells increase in number and develop unusual shape and features. They do not have all the features for us to say that it's cancerous, but it's still concerning to see this since it's not normal, right? This hyperplasia is most likely due to mutations and changes and increases the lifetime risk of developing breast cancer. Usually after breast imaging, such as a mammogram, if abnormalities are seen on the imaging, you will be sent for a biopsy where they will take out some of the breast cells/tissue and further evaluate it. And that's when they may notice the atypical hyperplasia. Next, having an increased body mass index or increased body fat relative to your weight and height. This has been attributed to an increase in circulating endogenous estrogen for the fat tissue. So yes, usually the ovaries are the primary source of estrogen production, but after menopause, fat tissues become the primary source of estrogen production. And not listed here, but also exposure to exogenous estrogen, so in the form of contraceptives, can also increase your risk of breast cancer. The last risk factor, and probably the most significant one that I would like to talk to you about, is related to genetics, specifically the breast cancer gene or the BRCA gene. So this gene is naturally found in the body, and in normal circumstances, it plays a major role as a tumor suppressor gene. This means that in normal circumstances, it encodes for proteins that stops cells from dividing uncontrollably. And what usually divides uncontrollably? Cancer cells or tumors. So it's a tumor suppressor. There are two types of BRCA genes, BRCA1 and BRCA2. Unfortunately, when this gene is mutated, that is when we have major problems. Although it's possible to acquire the mutation during your life, most are actually inherited. Having the mutation in either BRCA1 or 2 increases your lifetime risk of developing breast cancer by 70%. This is extremely concerning, so it's important to know if you should get tested so the proper preventative measures could be taken. It is recommended to test for the BRCA mutation if you have a family history of any of these cancers. That's because having the BRCA mutation increases your risk of not just breast cancer, but all of these. It is also recommended to get tested for the BRCA mutation if you have relatives that never had cancer, but were found to have the mutated BRCA gene. Women of the Ashkenazi Jewish descent are also recommended to test because about 1 in 40 of these women have a BRCA mutation, which is 10 times higher than the general population. Because all of these risk factors are significant for breast cancer development, there are clinical assessment tools to help determine the risk of developing breast cancer in the future. Depending on that risk, we can take the proper precautions and begin risk reduction management. There are different risk assessment tools, but the most common one is probably the Gale Model Risk Assessment Tool. This tool assesses the different breast cancer risk factors, and then it calculates the risk of developing breast cancer in 5 years and lifetime. So you simply enter the answers to the questions they ask about these risk factors, and at the end, it will provide you with the results. Unfortunately, the Gale model cannot be used to assess breast cancer risk in just any patients. There are patients who are not eligible. So just to clarify, because we are using it to assess the risk of breast cancer, it wouldn't make sense to use it in someone with any history of breast cancer. It's also not recommended for women with a condition known as lobular carcinoma in situ. In a nutshell, this is not cancer. It's very similar to atypical hyperplasia, but in this case, there are more abnormal cells, and the risk of developing breast cancer is 12 times higher with these patients compared to the general population. These patients have such a high risk of being diagnosed with breast cancer that there is no point of even using a risk assessment tool to check. We can pretty much guess that at some point in their life, majority would develop breast cancer. Same thing with patients with the BRCA mutation. No need to even use a risk assessment tool because their risk of developing breast cancer is so high, 70%, right? We don't need the Gale model to confirm this for us. Another group of women who are not candidates for using the Gale model to assess the risk of breast cancer are the ones who received chest radiation before the age of 30. Studies have shown that up to 20% of these patients can develop breast cancer by the age of 40. The Gale model plus other factors are highly important in clinical practice because based on the score that's generated, we can possibly provide patients with something known as risk reduction therapy. Risk reduction therapy is defined as therapy to reduce the risk of breast cancer in women who have an increased risk based on their medical history. As per the NCCN guidelines, the risk reduction therapy is indicated for patients with a 5-year Gale model risk of 3% or more. In other words, the patient's estimated risk for developing invasive breast cancer over the next 5 years is 3%. Lobular carcinoma in situ, atypical hyperplasia, BRCA mutations, and patients with prior chest radiation. Okay, now, for the moment we've all been waiting for. The therapies that have been shown to reduce the risk of breast cancer. So first, let's look at the risk reduction therapy options as recommended by the NCCN guidelines, and then I will provide more details about each one after. So first, prophylactic mastectomies, also known as a preventative or risk-reducing mastectomy, is a surgery to remove one or both breasts to reduce the risk of developing breast cancer. The NCCN specifically recommends a bilateral total mastectomy plus or minus a reconstruction. Reconstruction meaning it restores the breast shape after a mastectomy using implants, for example. So the good thing is that the prophylactic mastectomy can reduce the risk of developing breast cancer by 90% in the lifetime. The bad thing is that there's still a small chance that the patient can still develop breast cancer. You see, breast tissue can sometimes extend to the collarbone and armpit, and it's not possible for a surgeon to remove every last breast cell or tissue. Breast cancer can develop even in the small amount of tissue that remains. Mastectomies come with post-surgical complications such as bleeding, infections, and scars. And lastly, it's permanence. Irreversible procedure and can cause significant loss of sensation in the breast, which can have an impact on sexuality. You will no longer be able to breastfeed. All of this can lead to possible anxiety and depression in some women. Okay, so next option of risk reduction therapy is a prophylactic oophorectomy. This is a surgery to remove one or both ovaries to reduce the risk of developing breast cancer. Remember previously we discussed the risk factors of breast cancer and the impact of the patient's reproductive history. And one of the main takeaways from that was an increase in the exposure and duration of the estrogen progesterone increases the risk of breast cancer. So in order to reduce the exposure and duration, we can remove the number one production source of these hormones, the ovaries. The NCCN guideline specifically recommends a bilateral salpingo oophorectomy, which refers to removal of both ovaries and the fallopian tubes. Studies have concluded that a bilateral salpingo oophorectomy can reduce the risk of breast cancer by up to 50%. This procedure also reduces the risk of ovarian cancer, which can be seen in patients with the BRCA mutation. Because of that, it is usually recommended to strongly consider this procedure and kill two birds with one stone. Bilateral salpingo oophorectomy, just like mastectomies, come with some benefits, but also some side effects and complications. First, the sudden loss of estrogen can cause a range of side effects such as hot flashes, depression, difficulty sleeping, and lessened sex drive, osteoporosis, and heart disease. And lastly, ovary removal also takes away your ability to have children. The last category of risk reduction therapy are the pharmacological agents. These are oral medications that we give to reduce the risk of developing breast cancer. These agents are recommended to be used for 5 years. The NCCN have them as the preferred option over surgical approaches for patients with a history of lobular carcinoma in situ. The medication we will give the patient will depend on their menopause status. Menopause occurs when a patient's ovaries stop producing estrogen and progesterone, and she permanently stops having menstrual periods. So we divide them into patients who are premenopause and the ones who are postmenopause. For premenopause, the only option is tamoxifen. For postmenopause, it's tamoxifen, raloxifene, or a medication from the aromatase inhibitors drug class. Let's learn more about each of these. I won't spend too much time on them because I want to do a separate video about these agents so I can cover them more in depth. So first, tamoxifen. Tamoxifen is known as a selective estrogen receptor modulator. This simply means that in some tissues, tamoxifen acts like estrogen, and in other tissues, it blocks estrogen's effects. In the breast tissue, tamoxifen occupies estrogen receptors, blocking the estrogen from binding to its receptor. This reduces the effect of estrogen, which will reduce the exposure and duration of estrogen within the body. Studies have shown that it could reduce the risk of breast cancer by 50%. Just like the other risk reduction therapies, tamoxifen also has some things we have to consider. First, it increases the incidence of endometrial cancer in patients. This is because of its mechanism of action. You see, tamoxifen may block the estrogen receptors in the breast tissue and prevent estrogen from binding, but in the uterine lining, it actually acts like estrogen, right? It transforms itself into estrogen and it binds to these estrogen receptors and stimulate it. This leads to an increase in cell division in the uterine lining. The risk is about 1 in 500, which is higher than the general population, but is still considered low. And in fact, studies in patients with breast cancer, the results were clinically significant enough for the benefit of these drugs to outweigh this risk of endometrial cancer. Close monitoring for uterine cancers is required while the patient is on tamoxifen. Tamoxifen is contraindicated in patients with a history of DVT, pulmonary embolism, thrombotic stroke, transient ischemic attacks, or known inherited clotting traits. Next, raloxifene. Raloxifene is also known as a SERM, just like tamoxifen. Both block estrogen receptors in the breast, but raloxifene does not stimulate the uterine lining. So with raloxifene, there is a significantly lower incidence of uterine cancer. The trial that compared raloxifene to tamoxifen in postmenopausal women with lobular carcinoma in situ found similar reduction in breast cancer in both groups. In patients who we are concerned about fractures or osteoporosis, raloxifene is the preferred option. Both of these agents are contraindicated in patients with a history of thromboembolic events. Lastly, we have the aromatase inhibitors. Aromatase is an enzyme that can be found in the adrenal glands, skin, and adipose tissue. It normally converts androgen, which are sex hormones like testosterone, into estrogen. Aromatase inhibitors block the enzyme aromatase to prevent this from happening. In a postmenopausal patient whose ovaries are producing little to no estrogen, having the AIs also block this aromatase enzyme in the adrenal glands, skin, and adipose tissue will lead to even more lower levels of estrogen. AIs have been shown to decrease the risk of breast cancer by up to 65%. In terms of the cons of AI, we generally try to avoid them in patients with a history of osteoporosis. In patients with moderate decrease in their bone density, we can still consider an AI plus some bone protective agents. The AIs can cause hot flashes, muscle and joint pain, and cardiovascular events. Although the cardiovascular events are also present with AIs, researchers believe it may be less significant with the AI. Before I bring this video to an end, please note that for patients who are not at the menopause stage yet and do not want tamoxifen but are willing to take the AI, we have to induce menopause through what we call ovarian suppression, which is meant to shut down the production of estrogen from the ovaries. This can be done with either surgery by oophorectomy or a medication like leuprolide. Once this is achieved, the patient can receive an AI. That will bring this video to an end. I hope I helped you learn a thing or two. Very long video, but I hope you enjoyed. Feel free to leave your comments down below and like, subscribe. Thank you for watching this video and take care.